Today I'm going to talk about caustic ingestions. There's currently a 50-year-old male in the medical ICU who ingested an alkaline-based drain cleaner, or it was reported to be Drano, and he took 2 scoops of Drano and mixed it with 8 ounces of water, and he drank the water, and then he called for help. So the ambulance got there, he vomited en route on the way to the hospital, and then also they suctioned 150 cc's of bright red blood. And then he was intubated at the outside hospital for airway protection. So for an overview of caustic ingestions, there's about greater than 5,000 reported annually. 80% of these are in children due to accidental ingestions. And with adults, most adults who ingest these are used for a suicide attempt. So the severity and the extent of esophageal and gastric damage depends on the compound. So the corrosive properties of the substance, the amount, the concentration, and the form, so whether it's a liquid or a solid, and also the duration of contact with the mucosa. The most common ingestion is strong alkali, which is what this patient ingested. It's usually sodium or potassium hydroxide, and these are also known as lye substances. And these are in drain cleaners, household cleaners, and batteries. Less common would be acidic cleaners, and these are hydrochloric sulfuric acids. These are in toilet bowl cleaners, swimming pool compounds, and then battery fluid. And these are less ingested when I think they burn more, so they have a smaller amount that they can ingest. So the patho, with the alkaline ingestions, you get rapid liquefaction necrosis, and that is just necrosis. You get tissue formation, you get pus and a mass that forms in your esophagus with your tissues. And that leads, and it can extend through the mucosa and then the esophageal wall. And eventually the tissue fluids will alkalize the buffer it. So, and then with these substances you get extensive transmural damage. So you get esophageal, gastric, and duodenal perforation, medastinitis, peritonitis, and then sometimes death. The liquid lye, that causes more damage because it can spread and cover more mucosal surfaces. The solid lye is more localized injury to the esophagus. So the liquefactive necrosis, it lasts about 3 to 4 days, and it's associated with vascular thrombosis and mucosal inflammation, and it gets slopping and ulceration eventually happens. And so then over the next 2 weeks, the esophageal wall, it gets thinner due to the slopping, and then you get developed granulation tissue and fibrosis. And then re-epithelialization of the esophageal wall can take up to 1 to 3 months. Long-term complications, you can get stricture formations. These develop in about 1/3 of patients who do ingest these substances. And it depends on the depth of the damage and the degree of the collagen deposition. And usually these develop around 2 months post-ingestion, but it can occur as early as 2 weeks or even years later. So some pathoclassifications, it's first degree, second degree, or third degree. So the superficial mucosal damage and vocal erythema, edema, and hemorrhage, that's first degree. And also the mucosal swabs, and usually don't get scar formation with these. And with second degree, you get mucosal and submucosal damage, ulcerations, exudates, vesicle formation, and then granulation tissue and fibroblastic reaction producing scars, and that's when you can get your strictures. And then with third degree, you get transmural and deep ulcers, and then black discoloration and perforation of the wall. So to diagnose these, they do an upper GI endoscopy, and that's done within the first 24 hours. And they usually try to do it within the first, it's preferred to do within the first 12 hours. It's not preferred after 48 hours due to the esophagus being thin and you don't want to perforate the esophagus. So there are different grades. You can grade 0 to 3B. So grade 0 would be normal. This does not need any treatment. And then grade 1, mucosal edema and hyperemia. And then 2A, transmucosal blisters, hemorrhages, erosions, and whitish membranes. Grade 1 and 2A, they don't require any therapy either. And you can start a liquid diet 24 to 48 hours and then advance their diet as tolerated. So grade 0 through 2A is excellent prognosis. It's usually not associated with acute morbidity or stricture formation. And then grade 2B and 3A, this is when you get 70 to 100% do develop strictures. Grade 2B is just grade 2A plus additional ulcers. And then 3A, you get small scattered area of ulcers and areas of necrosis. And then 3B, which would be the most severe, is extensive necrosis. And with these last three, you want to do nasoenteric tube feeds after 24 hours. And then steroids are not recommended. They did not, in the studies that were done, steroids were not seen to decrease the rate of or the incidence of stricture formations. And with 3B, there's a 65% early mortality and need for esophageal resection with colon and jejunum. So as far as management goes, when you call poison control, the main thing that they tell you is to secure the airway. So our patient's airway was secured at an outside hospital. You want to do chest and abdominal films, and that's to look for perforation. So if it's in the mediastinum, then that indicates an esophageal perforation. Or and then if it's lower down, that's more gastric perforation. Supportive care, labs and vitals, want to look for signs of acidosis, shock, and hypotension, and then treat accordingly, and then make the patient NPO. Gastric acid suppression, so an IV PPI is preferred. This patient was on Protonix twice a day. If surgery is indicated for disc perforation or mediastinitis or peritonitis, and then broad spectrum antibiotics may be needed. You do not want to give emetics because vomiting will re-expose the esophagus and it can cause more damage, and then the acid will just make the damage worse. Neutralizing agents you do not want to use to try to neutralize the substance. That can release heat, adding to injury to the chemical destruction of the tissue. And also, nasogastric intubation to remove the agent is not recommended. This can induce, again, vomiting. You might perforate the esophagus. And also, when you go to intubate, you do not need to do a blind intubation because you could lead to perforation and then difficulty intubating. So an update on this patient, his caustic ingestion was graded as a 3A. He had extensive transmural damage and ulcerations. They repeated the EGD 1 week later and he did show improvement. They also inserted a J tube for feeding. And then he had a fever of unknown origin, so we just started on broad spectrum antibiotics. Any questions?
Anything, Brittany? Okay, that's great.